Okay, I suspect any of my private practice colleagues, and I was one of you for the first 8 years in my career, or for anybody who's not too persnickety, that you'll look at this talk and think, yeah, so what? Because we always ignore these small things. But we see more and more small things as time goes on, and I hate them, and I think we should ignore them. And I'm going to try and present my case why we should if anybody's still on the fence. I promised myself I wouldn't say this, but I've got to. I'm offended by this. This means that basically the bureaucracy everywhere assumes I'm going to be immoral and all sorts of bad things until I actually say that I have no disclosures. I have no disclosures to make. And I also must let you know before I do this talk that this is how I operate. No opinion is worth holding unless you can have it strongly. So I will come across as fairly opinionated about some of the things I'm saying. And by the way, I never know what I'm really going to say in a talk till I hear myself say it, so I apologize if I say something stupid. Educational objectives. Renal cancer biology is not nearly as bad as I used to think. And also, I think we could ignore just about all less than up to 1 centimeter renal masses. Incidentals haven't always been a problem because you have to actually see something before you have an incidentaloma. And a few years before I started my career, this was ultrasound technology. And I don't know how anybody read anything in this, but this was pioneering when it came out. Okay, now as far as renal incidentalomas go, I'm not going to talk about dromedary humps or pseudomass from scarring or fetal ovulation in columns of beta. I mean, those are well known. I assume you guys all know how to work around those. And otherwise, that leaves 2 types of renal incidentalomas. And I'm also not going to talk about one of the 2 types, and that is you're doing an ultrasound for gallstones and you see renal mass, or you're doing a CT for something else and you see renal mass. Those are incidentalomas, but that's of a different category. I'm talking about and they're not such a problem for ultrasound anyway. We don't use Bosniak in ultrasound, and I pretty much distill it to if there's meat, it could be cancer. If there's no meat, it isn't. And meat, solids, thick septation, nodularities, flow inside, whatever. So the kind of incidentaloma I'm going to be talking about are the little things that we didn't used to see, but now with our improving technology, we see them a lot, and as technology continues to improve, we're probably going to see them in everybody. If you have discomfort with our unequivocally saying something is such and such, just ignore it and put it in the report, no follow-up needed, you need to know that we actually deal with uncertainty of the renal tumors all the time, because in a large meta-analysis, 3% of cancers were misdiagnosed as benign. So we're already all living with this uncertainty anyway. Now, my general philosophy towards meta-analyses is garbage in, garbage out. I don't like them. I think people who base their careers on that just couldn't do original research. But at any rate, this is on the total number of biopsies, 29 of 931, so I trust that data. Okay. Before I wrote a paper I'll describe shortly, I didn't know nearly as much about renal cell cancer as I should have, probably because I'm old and lazy, but it's actually, I was reassured by the following statistics. Only 1 to 8% of 3 to 4 centimeter renal cell carcinomas have metastasized at time of discovery. You can ratchet it up a bit, and 5% metastasize by the time they're 4 centimeters. So basically a small renal tumor, for all intents and purposes, hasn't metastasized. That'll become important later. Next, about cancer biology, I guess. In small-sized tumors, 2.1 to 3.5 in one large study, they only grow, or in several studies, they only grow at 0.13 to 0.36 centimeters a year. So a typical renal cell carcinoma is very slow growing. In fact, they're known for hardly growing at all over long intervals. If you miss by what I'm talking about today, a 1 centimeter renal cancer, and if this cancer biology kind of holds through time and through sizes, if you miss a 1 centimeter renal cancer, it's not going to become 3 centimeters in size until 6 to 15 years, or a long time after you've missed it. And so it's unlikely to metastasize for quite a long time. If you use a 4 centimeter threshold, and if you can extrapolate those numbers, it could be up to 20 years before a 1 centimeter tumor gets to 4 centimeters and has a 5% chance of metastasis. So, if you misdiagnose a tiny renal lesion that actually someday, somewhere, proves to be a cancer, and if you call it benign, I argued the following 2 points, which I cannot quantify numerically, but I do not think they're insignificant. Some of those patients, maybe a lot of them, are going to have some sort of other imaging study between the 6 to 10 to 20 years that their tumor grows to a reasonable size. And if it gets bigger, it's going to be seen then. So, okay, so I miss a tiny one that's 8 millimeters. I don't care if somebody catches it 6 years later, it's not metastasized, patient gets therapy then. I don't have an ego for this sort of thing. I'm going for patient care. And so I don't care that I missed a small tumor if that's the situation. Also, to be crude, some people are going to die before their cancers do anything to them. So I think if you lump these 2 categories together, that's a relatively high percentage of renal cancers that you might miss that will eventually be discovered later or not be significant. I can't factor that in numerically or statistically, but to me it makes a lot of sense. Again, I strongly hold this opinion. Okay, now, first I'll broach the topic of small echogenic renal masses. Before I did my study, I had never retrospectively known of a cancer that ended up being bad or that I ever saw again that started out as a 1 centimeter or smaller echogenic mass. We're seeing these more and more often as technology improves, and we just can't follow all these up. It's just a waste of money in my opinion, and as are a lot of other things. And another gripe, CT scans. A number of my colleagues will describe less than 1 centimeter low density indeterminate lesions. I think that's just passing the buck. Because what that means is I'm going to equivocate and call it this. I'm not going to commit myself, but I expect a doctor who receives this report to operate on this advice, and I really hope that this doctor concludes that this thing is benign. I don't think that's right to pass off our obligatory duties onto somebody who knows less radiology than we. So as far as I'm concerned, if I'm looking at a CT scan, there's a low-density renal lesion less than 1 centimeter, and somebody who doesn't have cancer or a strong other history and make me that worried, I call them benign. I just blow them off. As I suspect a lot of my private practice colleagues do who are actually probably more pragmatic than some of us academic types. But I will acknowledge renal cell carcinoma can be echogenic. Absolutely and unequivocally acknowledge that. I know it to be true. That's not the point here. I'm just pointing out that if a lesion's less than 1 centimeter and it's echogenic, I will show data that shows that the chance it ever ends up being carcinoma are so small that we can and should ignore it. Flying in the face of that was a prior study which said all non-calcified echogenic renal lesions detected with ultrasound need a CT to rule out renal cell carcinoma. I don't think that's true. Okay, now to my study. Written up by my fellow at the time, Malaka Tani, who's in the audience now and is currently at WashU. I'm very proud of her. We did a retrospective study. We looked at adults. These results apply to people who don't have cancer and don't have symptoms of cancer, so I'm not talking about somebody who's got a melanoma or something like that. We found 120 echogenic masses up to 1 centimeter in size, for which we had an MRI or CT to prove what they were, or we had stability for at least 5 years. And we actually had stability up to over 10 years in some. We had a mean stability of 7.4 years. And also, I didn't load my less than 1 centimeter data set with a bunch of teeny tiny things. Most of the data set was 5 to 10 millimeters. So I didn't use tiny little things and then bias my results up to 1 centimeter. Of these 120 renal cell echogenic renal lesions, none were cancer by our methods. We either use a lack of increase in size for that. Actually, okay, I'm going through the statistics of the data for who these 120 were. Our largest category was, we don't know, but it's not cancer. 66 patients that either didn't increase in size over at least 5 years or went away. I don't know what it was, but in this sense, I don't know what they were, but I do know what they are. What I don't know is the exact name to put on them. What I do know is they're not cancer. And to me, that's all I'm concerned about. A reasonable minority were angiomyolipomas. And I'll show a couple examples of some weird things, calyceal diverticuli. This is our typical echogenic renal mass. Everybody sees those, we see them a lot. And people in my department want to recommend CT or MR to evaluate it now, to see if there's fat, see if it's AML. We also had some odd things. This echogenic mass here proved to be a calyceal diverticulum by anatomical matching. This echogenic mass even proved to be an accessory renal artery sinus that entered the lower pole in a weird spot. So there are a number of things these things can be, but what they don't be is cancer. So in summary, I would say that echogenic masses up to 1 centimeter in size, when you see them in the kidney, not only can be ignored, but should be ignored. I think we're wasting resources if we chase after these. You can call them angiomyolipomas, you can call them benign, you can call them benign echogenic lesion of no significance requiring no follow-up, or whatever you want to say, but I would strongly recommend don't follow them up and don't say it's at risk for cancer. Okay, so we move on. The only other basic indeterminate lesion is, what about the less than 1 centimeter anechoic but not increased through transmitting mass? Now, this isn't one of them. This is a 7 millimeter cyst with increased through transmission, no problem there. But we often see this, okay? Now, again, I suspect a reasonable number of you guys out there, you're looking at this thinking, why is he making a fuss about this? I'd call that a cyst all the time. But it doesn't through transmit. By the classical definition of a cyst, you can't call this a cyst. It's got to through transmit. But by analogy, I will go to a CT study, this white paper, whatever, by Lincoln Berland and a who's who of experts talked about CT management of low-density lesions. And they said, if it looks like a cyst but its attenuation doesn't prove it, call it a cyst, basically. So I think you can extrapolate to ultrasound. If it looks like a cyst and all it lacks is through transmission, if it's dark, doesn't look like it's got any meat in it, I would call it a cyst and never give it another thought. And I routinely do that. So, small renal lesions up to 1 centimeter, unless you look at it, if they're echogenic, ignore them. If they're not echogenic, if you don't think you can say there's a solid component, ignore it. Call it a cyst. Don't even mention it. That might be an appropriate thing in the future. I think someday in the future, we're all going to just have to not mention some of these things. But whatever, don't recommend follow-up. Okay, now, I figured I would probably go quickly and end quickly. So I've got time. You're a captive audience. I'm going to blather about a couple of things that came up to me as I was making this talk. Talking about little renal cysts, we do a lot of transplants. A lot of places just do a lot of transplants. Be suspicious of cysts you see in renal transplants. Put color Doppler on them. Not all cysts in renal transplants are cysts. This had the yin-yang, which I'll talk about shortly, but this waveform proves this to be a pseudoaneurysm. So we could have called this a cyst and ignored it and probably would have gone away, no big deal, but we would have been wrong. It might have been important. So I would color Doppler, and we routinely do color Doppler all cysts in transplant kidneys. Now, I'm going to poll the audience. This is an inguinal sonography. Obviously, yin-yang. Oh, by the way, I gave a talk in China about 12 years ago, liver transplant problems. I had an example of a pseudoaneurysm of the hepatic artery in transplant. I had a translator who was a resident in radiology, and she was translating as I spoke, and I got to the example, and I quite happily said yin-yang, expecting to get smiles of acknowledgement throughout the audience. Nothing happened. They said, what is this yin-yang? So at least in Beijing, this typically thing we think is Chinese isn't. And if you're speaking to somebody in a language they don't understand and you're waiting and waiting for a response that doesn't happen, you die 1,000 deaths on the podium, I'll tell you. Okay, so we got this yin-yang in the groin. All right? Now, show of hands. How many people say this is pseudoaneurysm? Oh, am I preaching to the choir here? Or did I intimidate all of you? Okay. It takes more than yin-yang to be a pseudoaneurysm, and I'm glad that nobody raised their hands. I'll go through the explanation anyway, but you don't put thrombin in this. Now, it's possible if you put thrombin in an AVF, I suppose maybe you could thrombose so quickly that there are no complications, but I don't know. I've not done that study, and there's no way I'd try to write an IRB to do it. So at least it seems like it'd be a bad idea to put thrombin. So what this actually was a saccular AVF with the feeding neck here from the artery, and on the other side, a vessel draining into the femoral vein, okay? So what you have to do for any yin-yang that you see in the groin, and these aren't common. I'd say AVFs in our experience about 1% of all the yin-yangs we get in the groins, but you got to get a waveform from the neck. And if you get a waveform with a low RI, I hate the term RI, but with a low RI, flows screaming through there because it's trying to get to the side. And you get the yin-yang just because if you got flow going from a small pipe into a big round area, it swirls around inside. That's all it does. So we never call in yin-yang pseudoaneurysm. We demand to see a waveform from the neck with pan-diastolic reverse flow is what we see. So what goes in comes back out. And I'm one of those dinosaurs who used to examine at the oral boards when they happened. And I was amazed at the number of residents trying to pass a study who didn't know this simple fact. So this is one of my soapbox things. If you're going to thrombose something with thrombin in the groin, make sure the feeding neck has pan-diastolic reverse flow. Okay, got nothing to do with kidneys, but thank you for your attention.